All right. Patient assessment. Does anyone have any questions before we get started?
How much you get?
Long. Got to bed at 3 this morning and got up at 7. Still not. All right. So part of patient assessment is being able to work in a cohesive team. This is what true teamwork looks like. You will only be as strong as your weakest link. And this is how you support a weak link.
Bring it apart and bring down fast. Run fast. Let's go, boy. Well, boy, you gotta take your feet. Come on. Hit it hard. Yes, you can do it. Come on. Yes, you can do it. You guys do it. Look at me. You have to hit it hard, though. You cannot hit it light. You have to hit it hard. Go. That's not hard. It's touch it. Come
Many of you tonight are gonna feel like that kid. All right, this is the patient assessment process. You learn scene size up on your first night. You learn primary assessment on your second night. You learn history taking on your third night. And last night we went over secondary assessment trauma. Now we're going to go into further detail for you guys. So what does scene size up include? It includes your dispatch information, surveying the scene, looking for hazards, what will kill you, your team, or your patient. Safety concerns based off hazards. What happened, mechanism of injury or nature of illness? How many patients are there? And based off all of this, do you need to call for more resources? Any questions? First thing we do though is protect ourselves, body substance isolation, personal protective equipment, gloves, if needed, eye protection, mask, gown. Some of the best body substance isolation is turnout gear. Not too much blood, puke, and poop gets through turnout gear. Any questions? All right, scene safety. I have no idea what this is, but we're about to find out. Yeah, I guess we'll be watching that. All right. All right, potential safety hazards. Oncoming traffic, one of the biggest ones. Unstable surfaces, leaking fuels or hazardous materials, down power lines. Anytime there's a potential for violence, if something is burning or about to burn, hazmat, any other dangers and crime scenes, which usually are associated with violence. Any questions? All right. So what can go wrong at a scene? Simple 4th of July celebration, barbecuing, lighting off fireworks, good time, what can go wrong? Pretty cool dog.
Kind of chilly. The reason it's kind of chilly is because the tallywhack is hanging out there.
Good examples of things that go wrong at scenes.
Someone at the police put on a tallywhacker. Tallywhacker. The guy said, "Oh, I just came from work." What kind of work do you have your hand on? What work do you do? And I thought there are people that are just paranoid. They think the cops are out to get them. Now, I think this woman's been stopped twice for the same thing. Kid standing up in the car. Okay? Take a look.
Why do you get on me?
I'm not getting on you. What's happening is, this is the second time now with the same thing. And she's not in the seatbelt.
She isn't the bell.
She was standing up.
She is not.
Look at the seatbelt right here.
What?
Take your driver's license off. Oh, I don't hate you. I like you. I'm looking out for your welfare. I hate to see your little one get hurt. She's gorgeous.
I pray every day that you will be safe. If you just stop talking and something will happen to you. Something will happen to you. If you had the children five like you said, you would understand me.
Ma'am, I have two children. I keep them in child seats all the time.
Don't touch you. What is it there? Calm down for a second. Don't fight with me again, otherwise you're gonna regret it. Okay? Calm down for a second. All right.
This next one's what you guys need to pay attention to, because this is how people get killed in EMS, fire, and law
Police
enforcement.
officer who's
Number one way you get killed.
of the driver, and you'll see why. Take a look. You just come on over here, man. If you're up here and anybody hits the back of my patrol car, it's a good chance you're gonna get caught somewhere between that car and your car. And if you're not caught in between, you may still get struck by one of the vehicles. I don't want that to happen to you. Hey, just like that. There you go. You didn't hear the cop go, "See, I told you." Just like that. Dealing with the public, it's a nightmare. Be right back with Tom Arnold right now.
All right. So park in a safe area, check in with law enforcement. They will be in control of the scene. Make sure scene safety is your priority. Don't turn high beams on towards incoming traffic. Any questions? So ways that law enforcement can secure a scene. For instance, a guy like this, it's not acting right, won't take his hands out of his pocket.
130, blonde hair, gray outfit.
Got me blonde hair and a gray outfit. I'm here. 12665. I'm gonna be out with one. We're to the rear of the Westwood Hall.
Copy.
Yeah, he's got a problem. He looks a little amped up. What's going on? Step to the car and take your hands out of your pockets. Take your hands out of your pockets and step up to my car. That's the second time I've asked you. You're making me nervous. Take your hands out of your pockets and step up to my car. Take your hands out of your pockets and don't resist. Now put your hands behind your back, or you're gonna get the taser. How much have you been drinking? Huh?
5 years.
How old are you, man?
22.
Where's your ID?
In my wallet, where the you think it is?
So you can chill out, or you can go to jail.
He's gonna wanna leave that in Las Vegas. All right, scene safety issues.
Don't get the one.
Coming next week, Assistant County.
This is ridiculous. It's snow and fog mixed together, and it made the visibility down to zero. And oh, watch out! Watch out! Oh, God. My car is gone. I need to get out of our car, but it's too dangerous. And this is fire. I need to get. Oh,
He's way too close.
this is great. My car. No. Look at that fire. Oh my God. This is crazy, man. What am I going to do about the charger? My charger. Oh my God. I don't know what that truck is on. Oh my God, those fires are crazy over there. I'm not going over there. I'm gonna check out the action over here. Woo. She don't remember the car she drives. Man, I think it's good. I'm gonna try to see if I can start saving people if they're hurt. So, oh my God, that fire. Oh man, I'm gonna go see if I can help someone. I gotta let you guys go. I'm sorry.
What if he's ET? You can just help people. Ouch. Same one. All right, mechanism injury. So we want to know the mechanism injury and trauma because it determines the amount of force and where it's applied to the body. If you can get an accurate one, it'll help the surgeons and the surgery team know where to look and cut first. Here's some examples of mechanisms of injury. That was a great idea. Nature of illness for medical. What appears to be wrong with the patient? Any questions? All right, so what is causing this guy's voice change?
It's gonna be a great race.
Yeah, I guess.
You're new around here, huh?
Yeah.
Well, you're good. Come on.
With a great pace that won't fill you up and never let you down. Make it a Bud Light.
All right, so again, first mechanism injury guides for where to look and where to start cutting first and where the patient is, because you only got about an hour. If they survive the first 5 minutes, generally they'll live an hour. No one dies between 5 minutes and an hour on trauma patients. Oh, this is great. Listen.
Oh,
That's a distinctive.
oh my God.
Help! Oh, shit, you gotta help me right now.
Hold your hand. Shit. Your leg's caught it.
That one's so good, you gotta watch it twice. Listen.
Oh my God.
Help! Oh, shit, you gotta help me right now.
Hold your hand. Shit.
Yeah.
Your leg's.
I don't know if I put the camera down, I kept going. Watching enough. Looks like a grandfather clock. All right, number of patients, based off that, what additional resources we need? How do you get multiple patients? Things happen. They're okay. Let's go. This is where you get killed. This guy's got no clue. He's just standing out moving around 70 miles an hour by. That's okay. Nobody else is going to slow down either.
Hi, I'm reporting a multi-vehicle south of 10. South of.
People take all of them.
Four vehicles involved so far. I'm not sure, there was one person walking around on the freeway. And was going walking on the freeway just before, the two cities. Was in the middle lane at his car, I'm not quite sure if. North so far. No, the lanes of the 110.
That was good.
I've been there. Sorry, this is Delta report, this is what the campus was downtown from that. 68 was. And then there was something.
It's how all this happens. Surely. Any questions on how that happens? So based off all that, you're gonna request additional resources if needed. That could be law enforcement, more fire units, more ambulances. Whatever it is that you think you need based off your scene size up. Any questions about scene size up? So we should always be considering spinal mobile restrictions. We're not gonna strap everybody to a backboard like we used to. But C-collars, they're having neck pain. If they have a deficit, they can't feel, or there's numbness in an arm or a leg, then we still strap them to a backboard. Other than that, we don't do that. That's scene size up. Any questions about scene size up? All right, ABCs. Oh, primary assessment. Okay, develop a general impression. What does the patient look like when you first see them? They look like they're about to die. They look like they're perfectly fine. They look like they're in distress. They look unresponsive. Then you want to assess their mental status. You need to know this AVPU. A is for alert. Are their eyes open spontaneously? Are they looking around? If their eyes aren't open, do they open to voice? Their eyes don't open to voice. Annie, are you okay? Then we hurt them. Bend their finger over backwards, give them a sternal rub, pinch behind their TMJ. And if their eyes open to pain, then we know it's P. And if the eyes don't open to pain, then we've determined they are unresponsive. AVPU. Alert, verbal, painful, unresponsive. We're going to check for a pulse while we're doing that. If their eyes are closed, we check carotid. If their eyes are open to look around, we check for a radial. They got a radial pulse, so their blood pressure is probably at least 80 systolic. Because it takes about a pressure about 80 systolic on the average person to get a blood out to the radial artery at that point. Going to check their breathing. Are they breathing? Are they breathing adequately and making sure their airway is clear and open? Now, if there's a problem with any one of those three things or something else you see, or they have uncontrolled bleeding, then you determine that they are a priority patient. Any questions about primary assessment ABCs? Yes.
I believe you want to make sure it's blood pressure, check for pulse, check for breathing, and then you said what was the last one?
Airway.
Oh, airway, all right.
Airway, breathing, circulation. ABC.
Oh,
Any questions? So while you're developing your general impression when you're looking at your patient, what's the environment look like? Like, this is the nature of illness, they're unresponsive. There's like a bunch of empty alcohol bottles, syringes. What's the house look like? What's the scene look like? Look around, it'll give you clues. Same with mechanism of injury. Someone's unresponsive trauma patient, no one's sure what happened. Look around at what could have happened. Ask the patient if they're alert. If you can help them identify yourself, ask them what their main problem is, their chief complaint. The chief complaint, which will be a test question, is what the patient feels is the worst thing that's wrong. It may not be their biggest problem, but it's what they feel it is. Any questions? On obtaining consent, remember 4 types. Expressed, they ask if you can help, they say yes. Implied, which is if they're unresponsive, so it'd be implied that they can. Informed, which is a written advance directive, and which we can't do, but law enforcement can. Involuntary. Those of you that haven't got 10 over 10s, it's probably going to be a question today. Yes.
So you can still touch the patient even if you don't have any consent?
You're supposed to get consent before you touch them.
But how do you test the ABPU?
Well, if they're not alert, then it's implied consent.
Oh, do that.
Don't go with these pictures as examples. The publisher pictures are horrible. I've found better ones. I look all the time. Any questions on what a chief complaint is? That's a small child describing what the Demogorgon from Stranger Things looks like. Any questions? All right, so again, any questions on AVPU, assessing the mental status? It's really important because you guys learned your Glasgow coma scales. AVPU is the first category. You get 4 points if they're alert, 3 points if their eyes open to voice, 2 points if they open to pain. And even if they're unresponsive and dead, great thing about the Glasgow coma scale is you still give them a point as a consolation prize. See, everybody gets a trophy of neurological emergencies. Any questions? There's AVPU with some more terrible publishers' pictures. Any questions about AVPU? There will be test questions. So if they are alert, you want to know how alert they are. So you ask them who they are, if they know who they are, if they know where they are, if they know what day it is, and if they know what the events were that caused you to be there, what happened. If they are, that's alert and oriented times 4. If they're missing one of them, then they're alert and oriented times 3. If they're alert and oriented times 3, you tell them, you say what 3 are. So like, let's say they're oriented person, place, and time, but have no idea what the hell happened. So you say alert and oriented times 3, person, place, time. That makes sense? Let's say they know who they are, but they don't know where they are, what day it is, or what happened. That's alert and oriented times 1, person only. That's how you say it. Any questions? So checking for a pulse. If they're alert, we're going to check the radio. We want to feel if it's present, how fast or how slow it is it regular or irregular, and how strong it is. If they're unresponsive, we go directly to the carotid. Any questions? And while we're checking for a pulse, we're also looking for any uncontrolled bleeding. Because uncontrolled bleeding can kill someone in about 5 minutes. Any questions? Yes.
Why is that not one of the first things?
So they've gone back and forth about ABC and CAB. And what they found out is you should just be doing all of it at the same time. And yes, there will be test questions that the patient's screaming after they chop their leg off with an axe and it's spurting bright red blood. The answer is going to be stop the bleeding, because if they're screaming, you know they're alert and their airway is clear and they've got good air. You can't scream if you don't have good airflow. So that's the critical thinking aspect. Is that a good answer? Airway. I want to make sure the airway is clear. Then all those things right there, that's breathing adequacy, not airway. They should be able to speak a whole sentence without taking a breath. If they can't, then we count how many words they can get. And that's a significant positive sign. Same with nasal flaring, accessory muscles in the neck and the clavicles. And of course, obviously, labor breathing. Any questions? All right. So they're unconscious. One of the big things we want to check is make sure they have a pulse. If they don't, start CPR and make sure their airway is clear. And if it's not, you have to clear it. Don't do anything else. The airway is not clear. And breathing is not adequate. We have to start bagging with the BVM. If they don't have a pulse, we need to start CPR. If they're bleeding profusely, we got to stop the bleeding. Nothing else in the compound E is calm. Any questions? Nothing else in your assessment comes until you have secured your airway, your breathing, your circulation. You do not pass go. Any questions? The biggest thing in fails skills that you will start tonight. If breathing is too fast or too slow, you need to ventilate. If you've got bubbly, gargling, crowing, or other abnormal sounds, you may want to consider an IGL. If you've confirmed with an OPA, they don't have the egatic reflex. Any questions? So breathing, are they choking? If they're not, how fast are they breathing? Are they breathing too fast or too slow? Are they breathing deep or shallow? Is their skin turning blue? We're going to teach you guys all about lung sounds. We want you listening to lung sounds every night in this class. Everyone in here should have good, healthy, clear lung sounds with good tidal volume. We want you to hear that literally hundreds of times. So then when you hear something that's wrong, you're going to be confident knowing that that's not what it's supposed to sound like. Any questions? The big thing is, are they moving enough air to sustain life, which would be adequate breathing? If they don't have adequate breathing, what do we do? Ventilate. Ventilate. All right, so Here is how to live, here, my goodness, I didn't get that caffeine. Here is how to listen to lung sounds as demonstrated on a serial killer.
Hey everyone, it's Sarah, registered nurse RN.com, and in this video, I'm going to demonstrate for you on a patient how to auscultate the lungs anteriorly and posteriorly. In the previous video, I went over an in-depth lecture about how to do this along with normal breath sounds and abnormal breath sounds. So be sure to check out that video after you watch this. So let's get started. First, I want to start out showing you the auscultation sites. I wanted to use these stickers so you can see about where I'm going to go with the stethoscope. And let me go over these real fast for you because these are the little landmarks of where you're going. We have our right lung over here and our left lung over here. And what we're doing is we're assessing the lungs. The right lung has 3 lobes: the right upper, the right middle, and the right lower. The left lung only has 2 lobes: the left upper and the left lower. So whenever you're listening, you want to start out at your apex up at the top of the lungs, right above the clavicle, just slightly above it, right here where you see these pink stickers. Then you're going to go down to the second intercostal space, a little bit over from where your breastbone is, the sternum. And this is where you're going to start assessing the upper lobes of the lung. Then you're just going to inch down a little bit and this is about the 3rd intercostal space, and you're going to listen here. Then go down to the 4th intercostal space. And this is one of the landmarks for the right middle lobe, your 4th intercostal space. So right here, we'll listen over here, our right middle lobe, and then we'll listen to our left upper lobe. Then we'll inch down a little bit and we'll listen a little bit more to that right middle lobe. And then we're going to be listening to our left lobe. And then we're going to go mid-axillary over here to the side where the armpit is, mid-axillary, 6th intercostal space. And we're going to be assessing our lower lobe. So it's right here on him. And then it's again right here. And you'll listen there, and then you'll just inch down a little bit and listen at the bottom just to assess those lower lobes a little bit. Now let's listen to the lungs with a stethoscope. Okay, before you begin, what you want to do is you want to perform hand hygiene, introduce yourself to the patient, and tell them what you're going to be doing. And whenever I listen to lung sounds, I like to listen directly on the skin with my stethoscope, not over the gown or over their clothing, because you can pick up other sounds that may sound adventitious when it's really not, and you just get the best acoustic sound whenever you listen directly on the patient. So you want to get your stethoscope and you want to listen with the diaphragm of your stethoscope because that's what picks up the best sounds. And what we're listening for is that full cycle of inspiration and expiration. And we're paying attention to what type of breath sound is it? Is it bronchial, vesicular, bronchovesicular? If you're not familiar with those sounds, check out my other videos because I have audio clips where you can listen to those. And we're also listening for any extra sounds on top of those sounds, like crackles, wheezes, stridor, anything like that we may be picking up. And another key is this skill takes getting used to. You have to practice it over and over, especially when you're listening over these areas because you're going to hear the heartbeat at the same time. So you're going to train your ears to listen for those correct sounds, like the heart versus lung. So practice this on yourself and on others so you can get comfortable with it. So what we're going to do is we're going to start at the top and we're going to work our way down. And we're going to start on one side and then compare that side because we want to see if we're hearing the same thing on this side as we are that side. So let's get started. Okay, what I'm going to have you do is take one breath in through your mouth and out through your mouth. And if you start to get dizzy or anything, let me know. We can slow down, okay? And we're starting up at the apex, right above the clavicle. Now we're going to inch down to the 2nd intercostal space, and this is where we're going to start listening to our upper lobes of our lungs. So it's about right there. Then we're just going to inch down a little bit to about the 3rd intercostal space and listen there. And we're going to go over and compare it. Now we're going to go down to the 4th intercostal space. And we're still going to be in the upper lobe of the left lung, but now we're going to be in the middle lobe of the right lung. So let's just go down just a little bit. Then we're going to go over here and compare. And then we'll just go a little bit down, maybe the fifth intercostal space, just still assessing that middle lobe. I'm going to go over here and compare. Now we're going to go mid-axillary, and we're going to be down in our lower lobes now. And this will be at the sixth intercostal space. Okay, we're going to compare sides. So if you just want to turn over here, we're going to go mid-axillary, compare sides. Then we're just going to go down just a little bit to stay in that lower lobe. And then we're going to compare sides. Now let's look at the posterior view of the back. Here, over on this side, we have the left lung, and over here we have the right lung. It's flipped compared to the anterior view. And what we'll do is we'll start listening up at the apex of the lungs again, and that's right above, slightly above that shoulder blade in this area where the green stickers are. Then we're going to go and we're going to listen between C7 to T3. And C7 is where your prominent starts, so right here, and we'll go a little bit below it, because C7 to T3 is going to assess the upper lobes of the posterior side of the lungs. So we'll go here and here, then we'll go down just a little bit. This is about where T3 is. And then we'll jump down to around T4. And from T3 to T10, we'll be assessing the lower lobes. In your posterior view, you have more ability to auscultate the lower lobes than compared to the anterior view where you're going to really be assessing the upper lobes. So then we'll just go down, listen here, listen there, we'll go there, and then we'll just go a little bit mid-axillary, almost mid-axillary, and listen over on these sides, and then down at the bottom and over here. Now let's do it with a stethoscope. Now we're going to listen posteriorly. Okay, let me tell you a trick with this. Whenever you're listening back here, as you learn if you watch the other lectures, you have the scapula back here and you have the vertebrae. And what you're trying to do is to get in between that scapula and vertebrae to listen to those lungs. And you don't want to go over the shoulder blades of scapula while you're listening to lungs, because it's really going to muffle out your sound and you're not going to hear a lot. So what you need to do is have the patient sort of just move their arms like this to separate those shoulder blades from one another, so you have some space to work with. So what we're going to do again, we're going to start from top and work our way to the bottom, and we're going to compare sides. So we're going to go slightly above the scapula, listen to the apex. Then we're going to go down in the area where C7 is, which is where your prominence is. Then we'll work our way down to where T3. And remember, this is assessing the upper lobes. And then we'll go down from T3 to about T10 and assess those lower lobes. So here we go. And again, just take a good deep breath for me in and out. Okay, and we're done with posterior. Okay, so that is how you assess the lungs with a stethoscope. Now be sure to check out the other videos in this lung series, like the audio files of the normal breath sounds versus abnormal, and the lecture that covers this material in depth. And thank you so much for watching, and please consider subscribing to this YouTube channel.
Any questions? All right. That guy's eyes. All right, breath sounds. This is what you're listening for.
Super accepted. In this video, I'm talking about breath sounds that are often referred to as rails, bronchi, and crackles. Which is which and what do you use for more practical purposes? When you're actually working and charting and giving a report or making a doctor call, this more accurately describes what you should be reporting. Rails and bronchi are outdated terms, and nobody really knows what they mean. The term you should use is crackles. But there's three different things you should include with the term crackles. First, the type of crackles. Are they fine crackles? Are they medium crackles? Or are they coarse crackles? And when do you hear them? Do you hear them during inspiration? Do you hear them during expiration? Or what part of inspiration and expiration do you hear them? And where are they in the lungs? Are they in the right lower lobe? Are they in the whole left side? Bilateral lobe? And that will give you a good description of the breath sounds. Crackles happen when there is air passing through and around fluid and mucus in the lungs, main stem, bronchus, or upper airway. An exception to that is atelectatic crackles, and of course caused by atelectasis. Atelectatic crackles are fine crackles in the end inspiratory phase, and they're usually in the lower lobes. My diagram here shows inspiration and expiration. Fine crackles sound like Velcro ripping apart. They can be atelectatic crackles, or they might be the beginning of fluid overload or pulmonary edema. Medium crackles are usually scattered about, and the fluid's getting more built up, or there's phlegm present. Coarse crackles usually when there's a lot of phlegm and fluid present. A few notes about crackles. If you hear crackles and when you listen to somebody's chest, if it is in their upper airway, their nose, or the back of their throat, it will echo all through their lungs. So ask them to clear their throat. And also, if the phlegm's in their chest, ask them to cough. See if it resolves itself. You don't want to disregard it because they were able to cough it out, but you want to be able to charge that they were able to clear it out, but saying what the phlegm looked like. Also, if your patient has an endotracheal tube or a trach tube, crackles are not normal breath sounds. They should have clear breath sounds just like everybody else. It just means that they need to be cleared out. They need to cough it up, and if needed, suction it through their tube. So just to summarize, the crackles are either fine, medium, or coarse. Chart when they happen in inhalation or exhalation, and where they're at in the lung. Okay, thank you so much. Bye-bye.
Any questions on what you're listening for? All right, so this has also changed. So when do we do high flow 2? So high flow 2 is when someone's in severe distress, trauma patients, severe difficulty breathing. We do not use it on chest pain and stroke patients, and we'll go over that after midterms on the reasons why. Anyone that's severely altered, we also put a high flow 2, but only if they are breathing adequately. If you come in and just order O2 without checking breathing adequacy, it will be an automatic fail. Because they're not breathing adequately, you put on a breather, that's going to kill the patient. If they're not breathing adequately, you have to assist ventilations with a BPM. Any questions? Try to keep the patient in a position of comfort. If they're dyspneic, which dyspnea is shortness of breath, they're going to need to be sitting up. If you lay people short of breath down, they generally die. Any questions? So assessing perfusion. So one of the best ways of assessing perfusion is to look at your patient, your doorway primary impression. What is the skin color? What is the skin temperature and moisture? And capillary refill. So everybody pinch underneath your nail so it turns white, then let it go. How long does it take to turn pink again? Should be less than a second. That's adequate end tissue perfusion. It's called capillary refill time. It's abbreviated CRT. You might see it on tests CRT. It means capillary refill time. What that means is that you have adequate perfusion to the end distal end tissues of the body there. So if it's 2 seconds or more, that means you're not getting adequate perfusion because it should take less than a second in a healthy person to refill. Does that make sense? So either you're not getting enough, there's not enough blood to refill it, or the heart's not pumping fast enough or hard enough, or your vessels aren't constricting enough to make it get there. But bottom line is, in the end, that's a sign of shock. Shock is inadequate perfusion. Any questions? So when people have good end tissue perfusion, their skin color is pink or a normal color. It's warm to the touch and it's dry. If they're cold, pale, and wet, or ashen cold and wet, or cyanotic cold and wet, there's no blood getting to their skin because they're having inadequate perfusion. And that is the definition of shock. Any questions? All right. So what's a priority patient based off your primary impression? People having difficulty breathing, people that look like they're about to die, they're unresponsive, severe chest pain, or any signs of shock, decreased papillary refill, or poor skin size. Any questions? No questions. All right. Moving on. And then based on that, are you going to load and go, or are you going to stay and do a history and a quick physical exam? Any questions? That brings us to history taking. 7 years now. All right, we're going to investigate chief complaint, and we're going to go over sample history and OPQRST in detail. So again, the chief complaint is the most serious problem voiced by the patient, but it may not be the most serious problem. Any questions on what a chief complaint is? There will be test questions on that. Sample history, again, signs and symptoms is your S. A sign is something you can hear, feel, touch, and smell. A symptom is something the patient tells you. Are they allergic to any medications? Are they taking any medical purpose? Any medications? Do they have any past medical history? And when was their last meal? And what were the events leading up to it? So if they have symptoms like pain or discomfort, you could actually drill down on the symptoms with an OPQRST, which isn't there. Where's the OPQRST? So O is for onset. When did it start? P is what for provoked it, what caused the pain. Q is for quality. What does the pain feel like? R is for radiation. Does it shoot off from the original site? Does it radiate anywhere else in the body? Like for chest pain, does it radiate to the arms, the jaw, the back? Severity is how severe is it on a scale of 1 to 10. And T is for time, meaning how long does it last? Does it come and go? Is it steady? How long are the episodes if it comes and goes? That's your OPQRST. That's how you drill down on the symptoms of your signs and symptoms from your sample history. Any questions? Yes.
I've heard that L referred to as last ins and outs.
Yeah, you can say it as that. I mean, there's times when that's appropriate, mostly in pediatrics though. Because pediatrics with dehydration, you want to know when their last outs was, which is poop and pee. With adults, it's not. With adults, the L is more important because of surgery. When they go put you under anesthesia, they want to know if you have a full or an empty stomach. And because depending on what you have, if you have food or water in your stomach, they're going to give you different types of anesthesia so you don't puke and choke on your own puke and die. But with kids, last ins and last outs is more important because you can actually measure if they're potentially dehydrated or not. Any questions? All right. That brings us to physical exam. So a rapid physical exam should take 60 to 90 seconds. You're gonna check the head to toe for anything that's going to kill the patient, and decap BTLS. Decap BTLS is for deformities, contusions, abrasions, punctures, decap, right? BTLS, burns, tenderness, lacerations, A. Wait, BTLS, there is no A. Lacerations and swelling. I don't know why I was thinking A. That's back in decap. There it is, decap BTLS. So the good news is they've had their head cut off. You don't have to do the whole thing. You just have to do the decap part of it. You can leave the BTLS off. Hopefully I don't have to explain that was gallows humor. So you're checking for decap BTLS on your head to toe and looking for anything that's going to kill them. Any questions? So remember, your ABC is already taken care of. You don't even go to the head to toe or the history if you haven't secured your ABCs. If you're going to check the head for decap BTLS, you're also going to check the eyes, channel light in the eyes, see if the pupil constricts. If it does, that means it's equal round reactive to light. We call that pearl. Pupils are equal round reactive to light. PERL, pearl. Then we're going to check the neck. We're going to look for jugular vein distension. We're going to palpate C1 through 7, see if there's any tenderness or deformity. And if needed, we're going to apply cervical spinal mobilization collar. Any questions? All right, we're going to palpate the chest. Of course, we're going to expose so we don't miss anything. We're going to palpate the chest. Crepitus. Crepitus is when you palpate and you feel or hear the grinding of broken bones. It's not what you want to hear, but it's positive pounding. You're going to listen to lung sounds and you're going to look for accessory muscle usage. Then you're going to palpate the abdomen again. Is it soft? Is there any decap BTLS? Is it distended? Is it firm? Then you're going to assess the pelvis. Now, if they tell you their pelvis hurts, you don't compress the pelvis because you're assuming it's broken. You definitely don't want to displace those plates and cut a major artery or vein. If they're unresponsive, of course, you're going to check it. If they say it doesn't hurt, you're going to check it, see if it hurts when you put pressure on it. Press down and you press in. Then we go to the extremities. We check all 4 extremities for not only decap BTLS, but good circulation, distal circulation, sensation, and movement in all fingers and all toes. Any questions? And that's your head to toe assessment. And while doing that, assign someone take vital signs, which is Glasgow Coma Scale, skin signs, which is critical fail if you don't get skin signs, blood pressure, pulse, respirations, and FPO2. Any questions? Then you're going to look at all of your positive findings together, form a primary impression, and then choose your treatment protocol based off that. Never, ever, ever base your treatment priorities or your protocols off one number from a vital sign. Vital signs are there to assist with creating a whole picture with your signs and symptoms that you found or positive findings on your physical exam. Any questions? Any questions? All right, Glasgow Coma Scale. This was developed in Glasgow or by Dr. Glasgow, I actually don't remember. So it's 3 categories: eyes, speaking, and motor. So even deaf people still get 3 points. See, everybody gets a trophy of patient assessment. So, huh? Yeah, not kidding. Obviously, I didn't drink enough caffeine. So your highest score is 15. You can't score above 15. 15 is fully alert and oriented. Dead is 3, or next to dead is 3. So you do it by category. So eyes, are they open spontaneously? You get 4 points. If their eyes open to your voice, they get 3 points. If their eyes open to pain, you get 2 points. If their eyes don't open at all, it's okay. We give them a consolation prize of 1 point. They're verbal. Are they already a person, place, time, and event? If they are, they get 5 points. If they're not already a person, place, time, if they're missing any one of those things, you give them 4 points. If you ask them what day it is, and they say the cat's being of the cereal, that's inappropriate, and has nothing to do with what you ask them, they get 3 points. If they say, that's 2 points. And if they can't say anything at all, you still give them a consolation prize of 1 point. Then we check motor. If they can follow simple commands, they get 6 points. If they don't follow simple commands, but they're still moving their extremities around, they get 5 points. If you go to do painful stimuli and they withdraw, that's 4 points. If they're seizing and the arms are coming in like this, that's called decorrobate posturing, that's 3 points. If they're going like this, away from the body posturing, that's called decerobate posturing, and that's worth 2 points. If they have no motor function at all, we still give them 1 point as a consolation prize. Then we add up the 3 categories, and that's how you get the Glasgow Coma score. Any questions? You got to know this. Yes.
You go back over when they're seizing it.
And yeah, so if they're flexing in, that's 3 points, called decorrobate posturing. And if they're going out like this, that's 2 points, and that's extension. So one real good one of the 2 is a fencing response neurological. Like when you literally get the living snot knocked out of you. Sometimes you'll do a fencing response. Your arms will go out like this. You see it in sports a lot, especially rugby. Sometimes football, not very often football, mostly rugby. Sometimes fights when somebody lands a great shot. They'll go. Want to watch the video?
The cord kit or the cord?
The corticate when they go towards the core. That's 3.
No, you're right. I just couldn't tell if you were saying the corticate or the corporate.
The corticate. Like a cat. Kit. And then the Sarah bit. Like a drill bit. Next question. Same thing. I want to watch the videos of people going. Yeah. Kind of like fun. But you guys are sick. I want to watch people get hurt. This is kind of fun to watch.
Right. They could get infit and playing well, or suddenly looks impressive. Oh, Lewis has got the wonderful courage from both players. It was a terrible pass that put him in danger. Spills wide Higgins. Opportunity. The hand pass comes across from Peckham. But the concern is with Lewis. Jordan Lewis will stretch that out immediately.
Well, he said, oh, that's just great. These sports in the world where you see that sort of coverage. It's not like this. Except that even without saying, there is you just have to call it completely. He was hungry, and they took a kid with him. And then ended up landing on his back. So 3 injuries over the course of 15 years from his hip, from his foot last year, he had papers in an elbow. And they're just the honest, tiny injuries are usually bigger.
Is known to have a tremendous right hand, and all these guys are, and he's helpful. Hit him right on the side of the jaw.
Yep, that's White Simmons, line clock is still down. If he's over, that's it. Oh, wait, he doesn't think he's not a shot. It's hard to do. Don't embarrass. Spinning fast distance. It's the one fire just saw. Right in you. Out over the lights and that's on fire. And he's got his little day. You boy, you know, from the fuck. See, Riley going back into Braxton. He's got it full speed, hit Lindstrom. And he didn't even touch him. He tried to get his foot down and he stumbled and in that Lindstrom. And it's, and you can see Ryan Johnson's right foot. And as he goes to plant it, he can't.
Number 984. Not a penalty. Cool. So get a white.
Any questions? Have all the head trauma out of your system for now? Got it. All right, then we're gonna reassess. That's usually done every time at the hospital. Check, see if anything's changed, monitor your vital signs every 5 minutes. Follow your treatment protocol.
I got a question.
All right,
That video, is that flexation or extension?
it's more extension. It's not really either. It's a fencing response. It's the closest they could find to extension.
Extension.
A couple of those guys did do some flexation.
That's what I was
Not very
wondering.
many. Most of the fencing response generally you go straight out.
Okay.
Any questions about the detailed exam? Just going over the same things. Not a whole lot to go over there. Any questions? All right. Again. Expose. Are they getting better? Are they getting worse? Or are they staying the same? Now, this will be a test question. Anytime there's a change in patient condition or level of consciousness, you must repeat the primary assessment, airway, breathing, circulation. There will be endless test questions on that and scenarios. Whenever there is a change in condition or level of consciousness, repeat the initial assessment, airway, breathing, circulation. Any questions? All right, so this is what it should look like. This is the next little example. How to do this. Go.
DSI seems safe.
CNC.
What am I dispatched to?
You are dispatched to an assault victim sitting on the floor.
What's my heart rate? Oh,
Yes.
do I need visual resources right now?
Human.
And C-fine considerations, I will consider C-fine. But you want to get on that? I'm locking up, I see an 17-year-old female in our parents' trailer. All right.
You have a 25-year-old male sitting on the floor.
Yeah. Still plans to have a set of here, pink one, right?
They look pink.
Okay. Locking up on my patient. Hi, how's it going?
Hey,
Okay. You know where you're at? You know what day it is?
the patient is where?
Basically, the person playing time of that. Well, take a look at the I feel it's already close.
You have a.
Inside more people on the job.
Sometimes our people.
Yeah. My airway is clear because she's talking to me.
Yeah.
And she appears to be bringing actively.
Yes.
At this time, I won't order another breather rate for 15 years. So what happened today? Which one is my best? I'm gonna make it. Going down the back of the head, checking on one of my gloves.
Yep. You, numerous lacerations and scar.
Behind the ears and the tube. Nope. I recognize what that was time. My pupils appear curled
on there, bro.
and no broken teeth or that. My trachea is mid letter JVD and no pain back the neck.
C-spine has standard copy.
Okay. Let's get a color on. Anything in the chest, any pain?
Ow. Standard palpation on both sides.
Okay. Double deep breaths one here, right? Lungs sound clear.
Very mellow.
I can adjust my adequately right now. Do you have any pelvic pain? Nope. Up from the pelvis.
Clear.
And going down the legs.
Upper extremity clear. Clear.
I'll suppose my patient now that I've seen any deputy.
No.
Okay. Get the backboard behind him, let's lay her down on the backboard, let's give you a head, and we'll do you have any allergies that we need to know about? No. Do you have any medications? No. Do you have any other past medical history? No. Go down the back a little bit. And pain back.
Yes.
And when was the last time you ate?
Jump there for around 3.
Yeah. Lay her down a little slowly, Evan.
All right, now, 1, 2, 3.
Any of that hurt? Yeah. Help in the abdomen real quick. Keep pain. Speed my finger, go hard. Hard. My finger might be able to. Good cavity phone. Push down. Pull up. Take your shoes off. Okay, after that, good top refill. Push down again. Push down again. Okay, and see it's under attack, all 4 extremities. Okay, go ahead and drag her up real quick. Okay, count.
On 3, 1, 2, 3.
Let's go and get her first wrap it in. We're gonna see if that amount of stuff is doing. If you want to get that done, August. Kind of journal. And the whole company is investigations. And what happened before you got beat up? My patient appears to have PCS of 15.
Well, 16.
Let's see.
Supposed to come back at 1:32.
One 24 or 78.
1:20
Okay.
16 respirations.
Respirations are 18.
I remember last in track. We're loaded up and getting going. How you feeling there, Phil? Any new pain or anything else for you? Ready? Yeah, ready? You all the way up? Stop.
Yes.
Going around. Come back in, get a second set of vinyl, so that everybody on the same one. Get a quick head to again. You want me to do pain up here? Okay. One.
Yes.
People still seeing pearl. No broken teeth, my airway's patent.
Everybody is approved.
Trachea pyramidal limestone, another JVD. Chest is stable.
Stable pain.
Happy man. Soft arm tender.
He comes back in.
Thumbs is still stable.
That's what she's rating.
Full 64. 64 for full, reservation 18.
132 for holes, reservation.
Another can be declared.
Clear?
Push down like you pushed out that test form. I still have your cap recall. Do it. Let's go.
One trying to go ready.
After. Still have trouble. Get another pair of that, we can go.
One side door.
Point your way, you do it. Okay, oh, what did he?
100.
Okay.
Okay, get ready to report.
First business, we have facility search to base report. First business, 71 paramedic. 3 with a 25-year-old female. Who was an assault victim. The patient states when he walked out, he was up. Patient is down, the person placed down in bed. With wounds to the head, with blood, bleeding is controlled. Neck is negative, trach has been lined with another baby D. Chest is tender compensation with pain, 1,030. Abdomen is soft on tender, lower extremities are negative, upper extremities move well, with strong sense throughout. I have a current set of vitals of 132 over pulse of 132, blood pressure of 100/56, respiration to 18. We have an ETA about 5 minutes right now for the works.
Didn't expose, failed. Here's, did he? Oh. Okay.
A 19-year-old female unconscious in a parking lot.
It's actually
Hi,
students
can
doing
you
it.
hear me? Can you hear me? Okay, can you hold these signs? Patient has a strong radial pulse.
Patient has a rapid radial.
Okay, and airway is clear.
Airway is clear, but you do have some blood on the lips.
Okay, and patient is breathing out.
That seems to be adequate.
Can you get her on, non-breather between the air? Okay, so. Taking a full body assessment, head up here clear.
You have abrasions to the face, a couple of broken teeth, but no airway compromise. Blood to the lips appears to have trauma to the tongue.
Okay, and eyes are curled.
Eyes are purple.
Anything coming from the ears?
Nothing jumping from the ears.
Okay, and chest
Chest is thin.
and abdomen
Soft and tender.
and pelvis
Not in urine. With two on. With two on.
and lower extremities.
You have abrasions.
And cavity flow of energy seconds.
Yep.
And cavity flow of energy seconds.
Yep.
Max, can you get a blood pressure test? Can you get respiration? Crystal, can you take a pulse? Is there anyone around that can answer questions?
Nope.
Signs, symptoms, allergies, medications, passion current medical history, last intake, events leading up to. Okay. Oh, and neck.
Respiration before deep. Respiration.
Vehicles.
Pulse will be made.
Okay, and skin is equal or dry.
Pale woman dry.
Exposing Sorry, forgot that. Straight knee, uncontrolled bleeding, or anything there. Lungs are clear and equal bilaterally?
Yep.
Okay. And
PPA is 140/80, 148.
89.
80.
Okay, so you wanna get on the side of the back, Gordon? Okay, and. Okay, ready?
Yeah.
On the count, roll.
1, 2, 3.
And checking the back. Back clear. Okay, and down on the head.
2, 3.
Okay, and you're gonna grab those motor shafts. Actually, we're gonna do a little long axis drive. Down on the head count
1, 2, 3.
and up on the head count.
1, 2,
Center
3.
on the board.
Now we're. Okay, and grab everything else. They just hold it.
The left and bowl.
Like. Okay, so are you guys gonna get on the feet? Max, you wanna get on the side? Right? Just get on the side first, gonna turn around. Okay, and 1, 2, 3.
Thank you.
And that's upside down on the green.
Okay, and strawberry.
All right, you guys get the point? All right, you got a 6-year-old female. Any questions before we continue? You have a 6-year-old female with complaint of right flank pain. She's alert, normal warm, dry skin, strong radial pulse, and breathing adequately. She's been placed on oxygen. You're doing a focus history. What should your partner be doing? Should they be preparing an ambulance stretcher? That. Obtaining a baseline set of vitals. Better answer than A. Gathering the patient's medications. Better answer than B. Repeating the initial assessment. Is there a reason to? So what's your best answer? You arrive on the scene of a motor vehicle crash. 22-year-old male to the front seat is conscious alert but has no visible trauma, complaining of neck and back pain. Before removing him, you should A. Perform a detailed head-to-toe assessment and apply a cervical collar. Reasonable. Maintain manual stabilization, head and grasp him by the clothes. Pull him out. Is that a better answer than A? No. Apply a cervical collar and immobilize it in a vest style device. Better answer. Slide in a scoop stretcher and rotate them laterally. Is that a better answer than C? Your patient's elderly male is confused and short of breath. He's on the 4th floor of the apartment building. You are extricating the patient when he suddenly becomes unresponsive. What do we do when there's a change in mental status? We reassess what? Initial assessment. Do we place it supine and start CPR? We don't know if he needs it. Do we give him good CPR and start extrication? Do we know if he needs it? Do we give him ventilator with a BVM? We don't know. Open the patient's airway. What's the question? This is not breathing, so they've already done the airway. So first thing you do is open the airway, begin ventilations. Any questions? You're dispatched to an unknown medical. You find a 52-year-old male sitting in a chair, sweating, pale, and cool. That's not good. You know that his pulse is rapid and irregular. In addition to oxygen, you should transport him quickly and consider requesting ALS. Pretty good answer. Document your findings and perform a rapid medical assessment. Is that a better answer than A? No. Conclude it's normal for it to be a regular pulse and be cold, pale, and wet. Is that a better answer than A? Put on a cardiac monitor. Is that in your scope of practice? So that's the best answer. 56-year-old male was found semi-conscious by his wife. His respiration rapid and shallow. Is that adequate? Not usually. Pulse is rapid and irregular. His blood pressure is low. Wife states that he complained of left arm pain. The most likely cause of his condition is, oh my goodness, cardiogenic hypoperfusion. Good answer. A ruptured aortic aneurysm. You have no idea. Is that a better answer than A? No. An acute myocardial infarction, also known as a heart attack. Is that a good answer? Or D, severe septic hypoperfusion. No signs and symptoms of that. So your best answer is A, because he's got low blood pressure. 67-year-old male presents with weakness, dizziness, and melena, which is dark black stool, usually means blood in your poop. Again, 2 days ago, he denies a history of trauma. His blood pressure is 90/50. That's not good. Heart rate's 120. That's not good. You should be most suspicious that he's experiencing gastrointestinal bleeding. Those are all the signs and symptoms of that. An intrathoracic hemorrhage, would that cause you to bleed in your poop? No. How about an acute appendicitis? Would that cause that? No. Or again, an aortic aneurysm, would that be any different than B? No. So your best answer is A. All right, let's go start airway real quick, see how much we can knock out before we go to break. You guys see the eagle? COS eagle. Pretty cool. Anyway. All right, airway. Thoughts for the day. Nobody knows you better than yourself. Nobody knows your strengths and weaknesses better than you do. Embrace and improve your strengths. Practice, educate, and train to improve your weaknesses. It will only make you better. Any questions? All right, we're going to teach you about, if we have time, the major structures of the respiratory system, the physiology of breathing, which we've already taught you, but we're going to go over again. Go over the signs and symptoms of adequate breathing, the signs and symptoms of inadequate breathing, and the assessments of what to do with someone who's not breathing, which is called apnea. And go over the process for assessing and managing inadequate respiration. What do? Bag them. Demonstrate how to open and maintain an airway, how to use a OPA and an iGel. And we're gonna go over what CPAP is, which is continuous positive airway pressure. We're gonna teach you about that too. All right, there's the anatomy of the airway. Any questions? Now here's something we hope you'll really like.
In order to stay alive, the body has to breathe air. We breathe in oxygen and we breathe out carbon dioxide. This process is known as respiration.
That'll be on the test.
Breathing happens automatically. Every day, the body breathes about 20,000 times. By the time we reach 70 years old, that's about 600 million breaths. All of this breathing occurs because of the respiratory system, which includes the nose, throat, voice box, windpipe, and lungs. At the top of the respiratory system, the nostrils bring air into the nose, where it's filtered, warmed, and moistened. Tiny hairs called cilia protect the nasal passageways and other parts of the respiratory tract and filter out dust and other particles that enter the nose through the breathed air. Air can also be breathed in through the mouth. The two airways of the nose and mouth meet up at the pharynx, which is located at the back of the throat. The pharynx carries both food and air and is used for digestion and respiration. One path is for food. This is called the esophagus, which leads on to the stomach. The other side is for air. It's called the trachea. A small flap of tissue, called the epiglottis, covers the air-only passage when we swallow. This stops food and liquid from going into the lungs. The larynx, or voice box, is located at the top of the trachea, the air-only pipe. This is where our vocal cords are. The trachea, or windpipe, which is a 2 to 3 centimeter tube, then extends downwards from the bottom of the larynx for about 12 centimeters. The walls of the windpipe are made strong by stiff rings of cartilage that keep it open. The trachea is also lined with tiny hairs. They sweep foreign particles and fluids out of the airway, keeping them from entering the lungs. The windpipe divides into 2 branches, and each one of these enters one of the 2 lungs of the body. Each branch resembles the limbs of a tree dividing into smaller, finer branches called bronchioles. The bronchioles end in tiny air sacs called alveoli, which look a bit like grapes. These structures enable fresh air to get to the air sacs, which are surrounded by tiny blood vessels or capillaries. The oxygen passes through these air sacs and travels through the capillary walls into the bloodstream. At the same time, carbon dioxide transfers from the bloodstream into the air sacs, where it gets breathed out of the body. When we exercise, the body needs more oxygen to feed the muscles as they work harder. The body responds by breathing more quickly and deeply. As the cells of the muscles use up more oxygen, the lungs have to work harder to keep up the supply. The respiratory system then speeds up to supply the body with much needed oxygen, and also to get rid of the carbon dioxide waste in the system. Over time, exercising also helps our chest cavity to get bigger, which enables the body to increase the amount of air it takes in. More capillaries form around the air sacs, so the body gets better at swapping oxygen and carbon dioxide gases. We can see how the body's respiratory system helps the body to move about and is influenced by regular and ongoing physical activity as well.
Any questions? So again, active breathing. Our diaphragm and intercostal muscles contract, which creates space inside the thoracic cavity, less than atmospheric pressure. Atmospheric air rushes in. Then we relax our diaphragm and intercostal muscles. That creates greater than atmospheric pressure, and the air rushes out. Any questions? So, without oxygen for a minute, your cardiac cells are going to get real irritable. After 4 minutes, your brain cells start to die. After 6 minutes, lots of brain cells die. And then after 10 minutes, they don't come back. Any questions? Any questions about air moving in and out and gas exchange at the alveolar level? You guys got this. Hypoxia. There's gonna be endless test questions with the word hypoxia. It's a vocabulary word you have to know. It means not enough oxygen to perfuse every cell in the body, which is metabolic needs. It happens when you're not breathing adequately or not breathing at all. Any questions? How do you know when someone's hypoxic? Well, they're anxious, high heart rate. When there's no oxygen in the brain, you start having mental status changes. You can see them using accessory muscles in their neck and their chest, and they start turning a little bluish. So heart attacks, fluid in the lungs, which is known as pulmonary edema, taking narcotics can cause it, smoke inhalation, stroke, chest trauma, shock, lung disease, asthma, which is a lung disease, and of course, premature birth before 36 weeks gestation because the lungs may not be fully developed. Any questions? All right, adequate breathing. Look around the room. Everyone in here is adequately breathing. Normal rate in death, good skin color, equal rise in chest fall. Any questions? Inadequate breathing. That's when they're struggling to breathe, they're losing consciousness, or in this case, they're choking on blood and their own broken teeth and body parts inside their airway. This guy's just doing as he was trained, but not exactly the best way to maintain an airway.
Sometimes I smile at things and sometimes I don't. I'm a little bit more serious sometimes, and people perceive that as being impolite, which it's not always the case. You know, just by the way I look, people see the shaved head. Little do they know that I shave my head because it's mostly bald anyways, and I would rather actually have no hair than do the comb over. 320, I'll be on a stop that vehicle. I just ran. Yeah, I'm following a red Camaro right now. It's got a cracked windshield, and it's occupied by two subjects that reside here in Loma. So I'm going to go ahead and light them up and talk to the driver about the cracked windshield. Shut your car up. Put your hands on the steering wheel. Front passenger, put your hands on the dash. Front passenger, put your hands on the dash. You got a driver's license? Huh? How come? You guys sit tight. Keep your hands on the dash and on the steering wheel, all right? Don't move.
What's this?
320, you have an available unit? Take your seatbelt off, man. Take your seatbelt on. The chance to get right. Yeah, nice trainers. Come on back here. No, walk backwards. Yeah, it's all right. Right here. Station your car. Steve, right here. Oh my God. 320, I need AMR and CDF to my location for a pedestrian versus vehicle. Pull over. Go around and pull over. Just be advised, it's a completely separate incident from my traffic stop. I'm gonna need one additional unit here to assist me with closing down the lanes. Can you hear me? Hey, don't move, okay? Stay still. I got paramedics coming for you. Stay still. Stay still. I got paramedics coming for you. You still want to move? He's gonna have probably some back and some spine and neck injuries. Just keep your arms down to your sides. You keep your hands on the dashboard, you understand? You keep your hands on the steering wheel, you understand? On the dashboard, you understand? Don't move, just stay there. You're breathing okay.
No, he's not.
Don't try and move, all right? Keep your arms down to your side. No, don't get up. You guys know who this guy is?
Yeah.
Tony, lay down, okay? Stay there. What's his last name? Where does he live?
On the next corner.
On the next corner? Lay still.
Trying to clear his
Lay
airway.
still. No, keep your head down, Tony. Tony, Tony, relax. Tony, relax. Tony, relax. Tony, no, you gotta lay down, man. Tony, you gotta lay still. Tony, you gotta lay still. Hold on. Vehicle versus pet, he's one on a bike. Alright. Hey, Glenn, what's your name? Tony. No, he's not answering any questions, but his name's Tony. Tony. We've been trying to get out. Remember what happened? It's still. Hurry up, cut. Take that guy out of the car and search him and cuff him up for me, okay? So the car was traveling probably 45 or so. I heard her lock up her brakes and I turned around because I was on my traffic stop. When I turned around, I heard the smack and he got rolled up on the windshield and got tossed. Yeah. You know where he got thrown? You know who got hit? Well, he got hit right where his bike is, and this is where he landed right here. Yeah, at least. The person that hit him is right up here. What happened?
The girl was coming this way, and then the guy was looking at you guys.
This is inadequate breathing. This is a 98% airway obstruction. And it's not adequate breathing. So there's your normal respiratory rates. You be familiar with those. Ha. The Marlboro man. So that right there, doorway impression. What's your prior impression patient? That is a classic COPD patient. Notice how well developed his accessory muscles are, because this guy is struggling to breathe every day of his life. Lifetime smoker. Same with the accessory muscles in his neck, the barrel chest. Classic. Any questions on inadequate breathing?
So that's a COPD?
Oh yeah. That's a classic. See, that's a poster child for COPD.
There's two types.
Huh?
There's two types. It's like blue bloaters and pink puffers.
Right. Yes. Blue bloaters, though, also are CHF, aren't they?
Right, of course, yeah.
Yeah, that's not really COPD, though. That's congestive heart failure.
It's COPD exacerbation.
Yes.
It's like, and
Yeah, they're two completely different etiologies, though, because CHF is generally from left ventricular failure, which then causes the kidneys to absorb too. We're going to go over that here in a little bit. But yeah, they're very similar. They both have the same end result. But yeah, he is the classic emphysema COPDer. Any questions about opening the airway? Head tilt, chin lift. If it's a pediatric, put towels behind their shoulders so the airway lines up with their big bobblehead. We're going to go to break soon. Any questions about the jaw thrust? That's in case you think they have spinal precautions. You don't want to head tilt, chin lift. Adam. You're not running all over the county tonight like last night.
You'll say that.
That's as fake of a picture as you're going to get. You're going to look, listen, and feel for air movement while checking to make sure their airway is clear. Any questions on OPAs? Any questions on MPAs? That's what an OPA looks like if you had a transparent cheek. Any questions on nasopharyngeal airways? Fake pictures. That's what a nasopharyngeal airway looks like if you had a transparent cheek. Any questions? Any questions on how to operate suction equipment? So you guys weren't even trained in all this. You're so far ahead. No questions on suction equipment. The recovery position, you need to know that for test. Left lateral recumbent with the airway down, so in case you vomit, you don't choke on it, so it drains out with gravity. Any questions about the recovery position? Oxygen. Never withhold oxygen from someone who needs it. Any questions? Anyone that's in cardiac arrest should have high flow too through a bag valve mask. Any questions about oxygen tanks and cylinders? I know you guys already got taught this in skills. Any questions about oxygen being the best oxidizer in the history of the world? Supporting combustion and supporting complete combustion. Best way to vaporize someone. Any questions about non-rebreather masks and nasal cannulas? That is a perfect placement of a non-rebreather mask. If you have it absolutely perfectly placed, you should be able to count the respirations by the dent every time they take an inspiration in the bag reservoir. That is a perfect placement of a nasal cannula. It does not get tied around their head like a hangman's noose. It goes into the nose and around the ears and back, tucks up front. Any questions? Any questions on BVMs? One man versus two man, one person versus two person. There might be a test question on, does mouth to mask give more tidal volume than BVM? The answer is going to be yes. A BVM is 800 milliliters of air volume. Your lungs are 1,500. So mouth to mask is going to be more. Any questions? All right, there's the two person and the one person. We don't have flow restricted oxygen power devices because we blame tools instead of EMTs. Any questions? All right. Remember the select maneuver. That's what we're going to pick up Thursday when we come back. Go to break. Be back at 8 o'clock. Ready to go into your new teams and do patient assessment.